Good morning, good afternoon, and good evening. Thank you so much for joining us. My name is Jessica Justman, and I'm the Senior Technical Director at ICAP at the Mailman School of Public Health at Columbia University. I'm also the Principal Investigator of the Population-Based HIV Impact Assessments Project, and have been so since 2014. Overseeing the first round of Thea surveys. And in this role, I'm truly delighted to welcome you today to our webinar on population surveys. The webinar is being held in conjunction with the current Jade Supplement on the Thea surveys. And today we'll hear details about how the surveys are providing critical information on the HIV epidemic and helping to inform the way forward. Before we begin, just a few housekeeping comments. We truly welcome your participation, and we'll ask you to use the Q&A box to submit any questions or comments you'd like the speakers and panelists to address. You can use the chat box and be sure to click all panelists and attendees to share any thoughts or experiences you may have about the topic. But these are thoughts or experiences where you're not specifically looking for a response from the speakers or panelists. And the webinar recording will be shared on the ICAP website after the end of the webinar. So I'm going to begin with an introduction and an overview on the population surveys that will be quite brief. And although I often put acknowledgement slides at the end of my talks, I really wanted to put this right up front and start by acknowledging all of the survey participants who allowed survey staff to come into their homes, ask sensitive questions, and collect blood samples and perform HIV testing and other blood tests. I also want to thank our colleagues at Ministries of Health, National Science Authorities, National Statistical Bureaus, and National Reference Laboratories, U.S. Centers for Disease Control and Prevention, and other U.S. government agencies and multilateral organizations, many in-country and international partner organizations, many ICAP colleagues, all of the Jade Supplement authors, and of course, our funding from PEPFAR, without which all of this would not have been possible. I also want to acknowledge all of the local and international staff who work tirelessly to conduct each survey. And I've listed here the logos from the surveys that are represented in the Jade's supplement. So, what are the origins of the population-based HIV impact assessment, or Thea project? Well, I would start by telling you that the Thea project has its foundation in earlier general health and HIV-focused surveys that have been conducted certainly in Africa and in other parts of the world as well. In 2014, PEPFAR provided support for the Thea surveys to shape HIV responses and guide progress towards the UNAIDS targets. Each survey is led by the Ministry of Health, is funded by PEPFAR through CDC, and has received technical support from CDC and ICAP or other implementing partners. The Thea surveys have been conducted now in 15 countries, and as you can see from your map on the right, 5 countries have conducted multiple Thea surveys. If you look at the country yellow and green, you can see those 5 countries, and in purple in Mozambique is where there's a first survey going on now. What are the key differences between those earlier general health surveys such as the demographic and health surveys or multiple indicator cluster surveys, as compared with the HIV-focused national household surveys. Well, the general health surveys really are designed to measure a wide range of health indicators across the general population to guide global health programs. And I've listed for you as an example what those indicators are, but they typically focus on maternal health and maternal and adult mortality and child and adult nutrition and so on. Many of them have included HIV prevalence, often though without return of results to the individuals. By contrast, the HIV-focused national household surveys really have looked at in-depth HIV indicators, particularly among people living with HIV who have been recruited from the general population. And these indicators, again, are listed here on the slide for you. And have focused on HIV incidence and prevalence of viral load suppression, achievement of UNAIDS targets, uptake of services, CD4 cell count enumeration, and home-based HIV testing with immediate return of results and counseling and linkage to care. So returning now to the Thea Project, this is a project which has sought to conduct nationally representative HIV-focused household surveys to assess the status of the HIV epidemic and the impact of national response programs. And I think many of you in the audience are very familiar with this, but for those of you who are less familiar with the project, I wanted to just provide all of this as an initial introduction. For nearly all of the surveys, they have had the same primary objectives, namely to estimate national HIV incidence and to assess national prevalence of viral load suppression, namely HIV RNA, with suppression defined as under 1,000 copies per ml. Each survey has a different set of secondary objectives, which are often quite numerous. But again, nearly all of them have in common subnational adult and pediatric HIV prevalence, HIV drug resistance, prevalence of detectable antiretroviral agents, the distribution of CD4 cell counts, and others. Here's a snapshot of Thea by the numbers. Fieldwork has now been completed for 18 surveys, and over 173,000 households have participated in interviews, and that's as of yesterday, and not counting the second round of the Malawi and Uganda surveys. Over 400,000 adults and children have been tested for HIV. 12 final reports have been released, and over 65 conference abstracts have been accepted and presented. And today we're featuring the August 1st, 2021 Jade Supplement, HIV Population Surveys, Shaping the Global Response. And I encourage you to go to Jade's website to look at it in more detail. The guest editors are Laura Porter, George Bello, Rejoice Nakambula, and myself. The supplement includes a foreword by Ambassador Deborah Burks and Iram Zaidi, and features details on methods, particularly sampling, field implementation, laboratory, and data architecture, some of which we'll hear about today, and also includes papers on results, HIV recency testing results, population viral load and viremia, HIV incidence and male circumcision status, and HIV awareness among men. And again, we'll hear some of those results today. Because we won't have time to go through every paper, I wanted to just sort of give you a snapshot of the methods papers, the 6 methods papers in the supplement. I'm not going to read the titles for you, but I'll tell you that we are going to talk in more detail about 3 of the methods papers here. Sorry, I have to set my phone to the side. Okay. And we also have 6 results papers in the supplement, and we're going to have a chance to highlight results from 3 of those papers. So here's the lineup. We are running from 9 a.m. to 10:30 a.m. so that we have ample time for questions and discussion. We're now going to see a brief video made by Ambassador Burks. We'll then hear a joint presentation on Thea methodology. We'll hear 2 presentations on Thea results, as indicated here. And then Laura Porter from CDC will take over as moderator and guide us through the Q&A session and the panel discussion. I think we can turn now to the video. So I will stop sharing my screen so we can do that. Thank you.
Hi, I'm Debbie Burks, and I'm so thrilled about the Thea data being released in a composite today. Just want to thank Eric Gooseby, who began this dialogue with me in 2013 to really launch these comprehensive surveys to really ensure that we were having the outcome and the impacts that we expected from our programming, both our investment in PEPFAR and our investment in the Global Fund. Those were launched in 2014. And multiple surveys were done rapidly by ICAP and now ICAP and University of Maryland. Why were those surveys so important? I think for 4 reasons. One, it ensured that the programs like Global Fund and PEPFAR and the host governments and communities were all looking and utilizing the same data to really understand the programs in their country, both by age and by sex and by location. And that really helped moving funds within a country to really address the gaps. But that took all of us working together in partnership, using the data for decision making. Secondly, it drove policies because it was very clear in looking at the data which groups were being left behind, from our key populations to young women, to men really under the age of 50 that didn't have comorbidities from HIV at that time. We're all being left behind, and policies and innovations had to change, ensuring access. There's no point in collecting data if there's not a joint understanding and that data isn't used to make the program better. Third, in identifying those key gaps, it allowed us to bring in the private sector to really help us address the issues of high incidence in young women and the issues of continuous lack of access of men to life-saving treatment. And thus DREAMS and MenStar was launched. And those programs are being tracked for impact on these serial Theas. And I think critically important, it showed that PEPFAR and Global Fund collectively were having the impact we desired, with continuous declines in incidence and continuous increases in older age prevalence, showing that people were staying alive with HIV due to our programmatic interventions. And fourth, it allowed the validation of the spectrum model for generalized epidemics with prevalence greater than 2. And so this really ends with a call to action. We really need better surveys for key populations and young women over time so we can assure that that programming for prevention and treatment is working. We really need key population and vulnerable population continuous surveys in addition to these broad FIAs. Secondly, we need to continue to innovate. It was the countries and the leadership at the community level and the host country level that allowed innovation to occur based on the data. So as a challenge to PEPFAR as it moves in to the 4th administrator to really use data in a constructive way to drive outcomes and impact and assure that we reach the SDG goal 3 together in 2030. Thank you.
Thank you, that was great. We're now going to turn to our first two presentations on Thea methodology, which will be done in two parts. So I'll introduce both speakers at the same time. Dr. Stephen Delgado will begin. Dr. Delgado is an epidemiologist and geospatial data scientist with over 25 years of experience in global public health and biomedical science. Currently, he's the Thea Project Technical Director, as well as the Director of the ICAP Survey Unit. The second part of the presentation will be given by Ms. Hetal Patel, who is a Senior Laboratory Scientist and currently the team lead for the survey support team within the International Laboratory Branch at CDC. Since 2013, Hetal has been actively engaged in the implementation of the Thea surveys, where she oversees laboratory activities as co-investigator on all Thea protocols. And in particular, she has played a critical role in supporting laboratory quality assurance measures, training plans, method validation, data analysis, QA testing discrepancies, resolution, SOP development, and providing mentorship along with many other laboratory activities for the survey. So let's begin with Stephen Delgado's presentation.
Thank you, Jessica. I'm going to go ahead and share my screen. All right, is that visible to everyone? Let me get rid of this.
Yes.
Cool. Okay, good morning, good afternoon, good evening, everyone. As Jessica mentioned, I will be providing a brief overview on Thea survey methods, particularly with an emphasis on highlighting the efficiency and quality of those methods in the context of the complex Thea surveys. Okay, brief overview of the presentation this morning. I will summarize in general terms, the survey design and scope for Thea surveys. Provide a brief overview of the survey response rates across the first cohort of Thea surveys. A brief overview of survey methods with a particular spotlight on a few elements. Community mobilization. I'm very pleased that we have one of our panelists, Bright Fury, the ICAP community mobilization lead in the South Africa office with us today. Also a brief spotlight on survey planning and survey monitoring. And then just a parting word on survey implementation in the context of SARS-CoV-2. So in terms of the design and scope of Thea surveys, the sample design, in general, they are nationally representative with a few exceptions. Ethiopia comes to mind as being a subnational survey, but generally nationally representative in nature, cross-sectional, and multi-stage cluster sample design, where we are sampling census enumeration areas as our primary sampling units, and then households within those enumeration areas as our secondary sampling units. And then finally, the residents of those selected households. As Jessica mentioned earlier, in terms of the sample size, our surveys are powered primarily to provide subnational level estimates of viral load suppression, as well as national level estimates of HIV incidence with prescribed levels of precision. In terms of our population of interest, we are enrolling the de facto household population within selected households. The age range has been variable across surveys. The current cohort of Thea surveys is generally limited to those ages 15 years and older. Earlier Thea surveys did include children in some cases, and also variable age ranges for the adult population for those earlier surveys. There are two main components, a questionnaire component and a laboratory component. In terms of the questionnaire data, these are computer-assisted personal interviews, both a household interview and an individual interview, really focused on HIV-related indicators. In terms of laboratory data, Hetal will expand on that in just a bit here, but home-based rapid HIV testing is a component, as well as laboratory-based supplemental HIV testing, measurement of viral load, CD4, ARVs, drug resistance genotyping and HIV subtyping, and in some of the earlier PHIA surveys, other biomarkers as well. In terms of data analysis, we have a very standardized tabulation plan that is adapted for country-specific use. And the data analysis involves weighting both for design weights, non-response weights, and non-coverage weights. This is a slide that Jessica presented earlier. On the left, a map of the countries. This map does include the 3 PHIA surveys that have been or are being implemented by our colleagues at UMB, the University of Maryland, Baltimore, as well as the 15 PHIA countries where surveys have been implemented or are currently ongoing. To note, the UMB surveys are in Nigeria, one currently ongoing in Zambia, and one currently ongoing in Botswana. On the right are the metrics regarding the sort of extensive scope of these surveys that Jessica reviewed earlier in terms of the number of surveys that have been completed, the incredible number of interviews, blood samples, reports, public release data sets, publications, and conference presentations that have been generated as a result of the PHIA surveys. In terms of response rates, thinking again about this through the lens of survey quality, these are for the earlier cohort of PHIA surveys conducted from 2015 through 2019, with the exception of Haiti. And these are the response rates for persons ages 15 to 49 years. But you can see on average about a 90% household interview response rate. Individual interview, I think as we're all aware, females tend to be have a higher response rate than we male counterparts do. But notable, once you get through the interview portion of this, that those who consent to blood collection among individuals who are interviewed, response rates tend to be a little more equal between females and males at low to mid 90% therefore for blood collection across the 13 earlier PHIA-1 surveys. So a brief word on methods. Again, I will focus on non-laboratory methods. Hedel will be presenting on the laboratory, but in general, the spectrum of activities that occur in the field begins with community mobilization, which I'll talk a bit more about briefly. As we mentioned, interviews, both a household interview and an individual interview, followed by blood collection, home-based testing, a fairly substantial amount of laboratory-based testing, and then return of results. And importantly, something that we began to implement fairly early in the Thea Project was active linkage to care. So not simply referring someone to a health facility, but actively facilitating and ensuring that those individuals are linked to care and treatment. So a word on community mobilization, which to me is an overlooked and undervalued component of surveys. I think that it is an essential element of high quality surveys. And in terms of quality, from a quantitative perspective, maximizing response rate, maximizing enrollment enrollment totals, but from a qualitative perspective and an efficiency perspective, ensuring that individuals at all levels, from the national level government down to the communities and households in which we work, that we are welcomed by governments, by communities, and by households to conduct these surveys. And I look forward to hopefully a bit of discussion with Bright when we get to the panelist stage of today's webinar. Jessica highlighted the methods papers a bit earlier. This is one of the methods papers that is in the Jade Supplement, authored by Karam and other colleagues. The front page being shown on the left, and the full spectrum of activities here on the right that are described in brief detail within the paper. So overall objectives of the surveys, a summary of the design and sample sizes for these early surveys in Zimbabwe, Malawi, and Zambia, eligibility, consent, and recruitment, training. It does contain a bit on community mobilization, and on through the spectrum of field-based activities and ultimately the data analysis that occurs for these surveys. In terms of methods, and again, looking at efficiency and quality in these very complex biomarker surveys, something that occurs before we ever go to the field is deployment planning. And I think this is an area where the FIA surveys have really both evolved and excelled. On the left, you will see a map that is the country of Uganda, with a very nice display generated by the CDC fellow in Uganda, Brittany Gianetti, showing the center points are the satellite labs in which we work. And then Hedel, I think, will describe that a bit more. And then the movements you see in there are the plans for the efficient movement of each and every team that is operating in there. So from moving from their first EA to their last EA, how do they move as efficiently as possible from one EA to the next, and also keeping in mind the efficient transportation of samples from the enumeration areas in which we work to the satellite labs, and from the satellite labs, supplies from the satellite labs out to the teams in the enumeration areas where they're working. The colored portions of the map indicate the language profiles of the countries. So in countries where we have multiple languages being spoken, it is important to be cognizant of the predominant languages being spoken so that we hire and deploy teams adequately and efficiently to meet the language needs that as they are distributed across the country. Early on, we are also using this information to help select the actual locations of these satellite labs, balancing the number of satellite labs with efficient transportation logistics between labs and the enumeration areas. Another aspect of surveys that is incredibly important is the monitoring of activities, both in person and remotely. On the left is a diagram, a schematic that is present in the methods paper that we alluded to earlier, and one that I will mention briefly subsequently, is the incredible data collection and data management architecture that underlies the FIA surveys and enables near real-time monitoring of what's going on in our survey. So important metrics like response rates, enrollment totals. We have a large spectrum of lab metrics in terms of sample quality and the quality, the efficiency and the quality with which those samples are collected. And a big thing that are an evolving thing is monitoring the geolocation of field teams, but also ensuring that they are in the correct places, that monitoring that geolocation of the teams relative to the EAs that we've selected, and ensuring that they have navigated to and successfully located the EAs in which we're working. This is another of the methods papers that Jessica mentioned earlier, data architecture to support real-time data analytics. And this also contains in quite a bit of detail a description of the data architecture diagram that we saw on the earlier slide, and the spectrum of things that article describes in terms of the CAPI interview, the collection of data regarding specimen collection and testing within the household, the data that are generated in our satellite labs, the data that are generated in our central labs, and after data collection, the cleaning and merging that go on, the data dashboards that allow us to do the real-time monitoring to ensure the quality of our surveys, and always paramount is the security of our data and controlling access of that information. So finally, just a word, I think we were, a number of our FIA surveys, Uganda and Malawi in particular, were interrupted in March of 2020. We resumed Uganda, I believe, in October I'm sorry, March of, I can't remember what year now. But we resumed Uganda about 6 months later in October of last year. And we resumed Malawi, I believe, in January of this year. So we have surveys ongoing in Malawi and Eswatini. So we have gained, out of necessity, a lot of experience in conducting these surveys in the context of the pandemic within each country in which we are conducting surveys. So in conjunction with our collaborators at CDC, we have created guidelines and SOPs for safely conducting our surveys. The title of one of the key documents is highlighted there, our recommendations for implementing these surveys. We have developed mobile phone-based staff symptom screening app for daily reporting of staff symptoms. And we have developed a DHIS2-based data management system to track incredible amount of information that flows in daily for monitoring the health and well-being of our staff. And we look forward to addressing this topic more fully in a future surveys webinar. And with that, I will say thank you and hand it over to Hedel.
Thank you, Steve. Good morning, good afternoon, or good evening, everyone. Hope you can see my slide. Thank you to my colleague, Stephen Delgado, for laying out the background. I will continue to build on the methods section, primarily focusing on the laboratory component of the FIA surveys. I am presenting on behalf of my laboratory scientists, colleagues, and friends globally. Part of developing laboratory structure for the FIA surveys was built upon lessons learned from other surveys, such as the Kenya AIDS Indicator Survey, various demographic health surveys, the first Swaziland HIV Impact Measurement Survey. So lessons learned from these previous surveys served as the guiding principles for the FIA surveys in two major areas. Firstly, to ensure that all participants receive accurate HIV test results, and second, the samples that were collected, transferred to a laboratory, processed into plasma and dried blood spot specimens within 24 hours, as we define it in the survey as arm to freezer within 24 hours. And this was necessary for molecular testing that was identified in the protocol. So I would like to request to bring your attention to the testing portion first. Almost 9 different test methods were described in the protocol, from HIV rapid testing to quality assurance in retesting, confirmatory testing, CD4 testing, the viral load, early infant diagnosis, lag avidity assay, detection of antiretrovirals, and drug resistance testing. In order to meet the testing requirements, ensuring collection of sufficient blood volume was critical. Keeping that in mind, venous blood draw was performed for all participants that were greater than 2 years, in which approximately 14 ml of 4 ml and a 10 ml tubes were collected. And a 1 ml finger prick was performed for participants that were aged less than 2 years, or in case when there was a venous field in blood collection. Additionally, the whole blood samples were processed into 4 plasma aliquots, and up to 2 dried blood spot cards were prepared. Once testing was completed, all clinically actionable results were returned to the participants. And we will review various testing points in the next couple of slides. Here, you see detailed description of specimen flow at various testing points within the survey. In general, samples moved from household identified in the blue box to an interim laboratory, which we call the satellite laboratory for the survey. In the middle green box, which is identified in the middle green box. And finally, to a central laboratory. Samples collected in the household were tested for HIV diagnosis following country's national HIV testing algorithm, and all positives also received point-of-care CD4 testing. Results were immediately returned to the participants. At the end of each day, samples were then transferred to a satellite laboratory for additional testing, such as QA retesting, which included first 50 samples collected by household testers using the national testing algorithm, and for all positives, confirmatory genius testing was conducted. Whole blood samples were then processed into plasma and dried blood spots before storage. Trained staff worked late into evening hours to ensure timely storage of all processed specimens within 24 hours. On a weekly basis, frozen specimens were transferred to a central location for viral load and early infant diagnosis testing. Subsequently, lag avidity and detection of antiretroviral and drug resistance testing was performed at the end of each survey. For the survey, satellite lab became a critical point in maintaining our sample integrity. During the pre-implementation phase, the laboratory staff conducted various satellite lab assessment within the laboratory network. Selection criteria included 2 to 3 hours of driving distance from a selected enumeration area, also identified space needed for specimen processing, testing, and storage of supplies, electricity, and waste management. And these were the few important factors. The map on the right showed the 6 selected satellite laboratory and 1 central laboratory identified as NRL. The green indicates samples could reach the nearest satellite lab within 2 hours. The orange to red indicates EAs that are located greater than 4 hours from a satellite laboratory. However, this region of Rwanda is remote, mountainous area, and special considerations were made. Selection of central laboratory was based on capacity to perform viral load, early infant diagnosis testing, and to ensure it had sufficient space to store approximately 8 to 10 -70 freezers, which varied by countries. Overall, greater than 98.6% of specimens collected, and here across 13 surveys, met the 24 arm-to-freezer requirement as defined in the protocol. Greater than 99.8% of specimens had satisfactory condition, i.e. no hemolysis or clotting, were observed. For retesting, a concordance of 99.4% was achieved. The photo on the right shows the remaining biorepository from a FIA survey in a country. In all, more than 116 -70 freezers are stored across multiple countries. In the next few slides, I will just like to highlight the lab-focused articles as it's part of the supplement. The first one here describes in detail the overarching laboratory process described in the manuscript titled A Comprehensive Approach to Assuring Quality of Laboratory Testing in HIV Surveys, Lessons Learned from Population-Based HIV Impact Assessment Project, where Yen Duong and myself share the first authorship. The top right panel lists various lab training cascades defined as training 0 to training 5. The first 5 trainings, training 0, which is training preparations, training 1, training of trainers, T2, which is training of satellite lab procedures, training 3 is just focusing on training of household procedures, and training 4, central lab or molecular training, were conducted prior to survey implementation. And the last training, training 5, training of lag avidity assay, was conducted at the end of the survey. All trainings consisted of both lectures and practical sessions, and these were conducted by laboratory subject matter experts. In total, approximately 3,355 testers were trained on various lab procedures, and this combined staff at all levels, the household, satellite, and central lab staff. Photo below is from a large training 3 taken during a practical session. The article here by Wetch et al. Defines how one of the primary objectives of FIA surveys is met: to estimate the national HIV incidence among 15+ years. The HIV-1 recent infection testing algorithm, RITA, is defined with addition of antiretroviral drug detection to improve accuracy of incidence estimates. The flowchart describes RITA-1, the lag and viral load algorithm, and RITA-2, the lag and viral load and ARV algorithm. For FIA surveys, RITA-2 was used to calculate final incidence estimates, and the algorithm included positive specimens tested as recent by lag avidity assay, further filtered by viral load greater than 1,000 copies per mil, and no detectable ARV. In 13 surveys, there were a total of 301 specimens identified as recent infection by the RITA-2 algorithm. Lastly, highlighting the article by Damal et al. Successful use of near point of care early infant diagnosis, EID, in NAMPHIA to improve turnaround time in National Household Survey. The manuscript defines various quality assurance measures that were established for implementing a point of care instrument for EID testing. Relying on pre-established network of gene expert instruments used for TB screening, the Namibia survey utilized the same instruments as satellite laboratories to test for EID using EID-specific cartridges. Bringing testing closer to participants avoided delays and allowed timely return of critical EID results to the household. Since this was being done for the first time in the survey, all EID specimens were also tested at the central lab using the Roche Cobas HIV-1 qual assay. A concordance of 100% was observed by both methods. Finally, I would like to congratulate all our authors on their publication. We have successfully developed multiple innovations to the surveys, and few are highlighted here. All HIV positives were further tested by a confirmatory assay, and this also confirmed the overall positive predictive value of the national testing algorithm. The PIMA CD4 testing was successfully performed at the household level. As just defined earlier, the EID POC was used in both the Namibia and the Kenya surveys. Any discrepancy in testing between household and laboratory was reviewed in case-by-case basis and adjudicated for proper follow-up, and in some instances required household revisits. The survey established a nationally representative biorepository of matching plasma and dried blood spot specimens for any future testing for any disease of interest. Finally, within the laboratory program, we have established a regional capacity of fellows who support various laboratory activities. Shown in the picture to the right are previous fellows, Alex and Rex, performing the PIMA CD4 instrument verification prior to survey start. With each survey implementations, multiple challenges were observed, and these became driving forces to innovation. And few are highlighted here. With initial surveys, maintaining large training sessions were becoming increasingly challenging. We also wanted to maintain overall quality of training. Therefore, in subsequent surveys, we reduced the number of people trained on PIMA CD4 testing. We also increased focus trainings on testers directly involved with their specific tasks and provided instructor-led demos for other cadres who were indirectly involved with lab process. For example, team leads received demos instead of conducting hands-on training. In case of blood collection, 1 ml blood collection via finger prick requires practice, and this technique improves over time. For the initial surveys, we had introduced the refresher trainings while the teams were in the field. We increased the training opportunities, refresher trainings, etc., to overcome this issue. In some instances, participants refused collection of two tubes of blood, and therefore we provided job aids with improved messaging on the amount of blood that was being collected for the survey. For example, a 14 ml of blood is approximately 2 tablespoons. The logistics and safety was an evolving activity. We started to review procurement lists at least 6 months prior to the start of the training cascade. Finally, the biohazard waste manager was often redirected to a nearby health facility if the selected satellite laboratory did not have the capacity to properly manage the biowaste. In summary, timely engagement of all subject matter experts, from laboratory scientists to epidemiologists to statisticians demographers, and clinicians have helped contribute to overall success of the FIA surveys. Adhering to strict quality control measures during pre-implementation, implementation, and post-implementation phases, and some examples that are listed here, have provided accurate and reliable quality data. With that, thank you for taking time to attending our special session, and I will hand it over to the next presenter.
Great, thank you so much, Hedel. We're now going to hear a talk from Dr. Christine West. Dr. West has worked for CDC for 16 years and is a captain in the US Public Health Service. She holds degrees in both nursing and epidemiology, and she serves as an epidemiologist on the General Population Surveillance Team at the Division of Global HIV and TB. And she's a PI on the Uganda and Lesotho 2020 FIAs, and led the paper that we're going to hear about on unawareness of HIV infection in men across 13 countries. Dr. West.
Thank you, Jessica. Just going to share my screen. Can you see that okay?
Yeah.
Great. Yeah, thank you. Good morning and good afternoon, everyone. I'm excited to present the highlights from our analysis on unawareness of HIV infection among men aged 15 to 59 in 13 sub-Saharan countries based on the findings from the FIAs 2015 to 2019. Despite the higher disease burden among women as shown here, HIV outcomes are worse in men than women, and men are experiencing more AIDS-related deaths than women. This is largely reflective of the gaps in testing and treatment coverage among men. This treatment gap also contributes to further transmission and a higher number of new HIV infection among men's sexual partners. And a major findings, as was pointed out from the FIAs, has been the testing gap or reaching the first 95 UN AIDS goal in men. With the recognition of the poor testing coverage among men, emphasis of HIV programs has been to identify undiagnosed men living with HIV with proactive and innovative approaches. Men lack universal entry points for testing compared to women who utilize reproductive or family health services more readily. Shown here are some of the approaches such as self-testing, men's clinics, community-based testing, and partner testing, which has shown some success. The focus has been on never tested in younger adult men, but additional strategies are needed to reach men who once tested negative but remain at risk for infection. The objectives of this analysis were to describe unawareness of HIV positive status in men aged 15 to 59 years across 13 countries and identify risk factors of unawareness among men living with HIV who ever tested. The goal of the findings in this analysis is to develop and inform targeted interventions and to support existing strategies to reach men living with HIV who are unaware of their HIV positive status. Availability of interview and biomarker data provided a unique opportunity to examine these factors related to unawareness. Face-to-face interviews captured information on demographics, testing, sexual factors, and use of HIV-related health services. This, along with the HIV and ARV testing, as we just heard about, which screened for first and second line HIV treatment regimens, allowed for the determination of HIV status and defining unawareness. Participants who tested positive for HIV during the survey were considered unaware if they reported having a negative or unknown HIV status and ARVs were not detected in their blood. We used data from FIAs completed in 13 countries during 2015 to 2019 with generalized HIV epidemics, shown here in purple. All except Ethiopia were nationally representative cross-sectional household surveys. Ethiopia's survey represented only urban populations. Each survey used a two-stage stratified cluster sampling design. Both biomarker and interview data were merged at the individual level for this analysis. We pooled data across all 13 countries and used weighted methods that account for survey design to describe unawareness in men, and long binomial regression was used to assess which factors were associated with HIV unawareness among HIV positive, unaware, and HIV negative men. As shown in the flow chart of the study population, of those interviewed, 114,776 men provided a valid blood specimen with a definitive HIV testing result. Among those with definitive results, 4.4% tested HIV positive across the 13 countries. Of the 7,430 HIV positive men, 33.7% were unaware of their HIV status based on self-report and laboratory detection of ARVs. 14% of HIV positive men who reported being as unaware of their positive status were reclassified as being aware after detection of ARVs. Most of the unaware HIV positive men reported they had ever had an HIV test at 63%, and 37% reported they never tested for HIV. Not shown here, but of the unaware men who ever tested, most reported they were HIV negative, and approximately 8% reported they never received the results, didn't know the results, or results were missing. The group of unaware men ever tested was the focus of our analysis. Overall, we found Southern African countries had the highest HIV prevalence among men, followed by Southeastern, Eastern, and Western African countries. Higher unawareness was found in Western African countries compared to Southern, Southeastern, and Eastern African countries, except Tanzania, where 46.8% of men were unaware of their HIV positive status. Most unaware HIV positive men were not virally suppressed, and 48%, almost half, had a CD4 count less than 350 cells per microliter, 18% of whom were severely immunosuppressed with a CD4 count of less than 200 cells per microliter. The next three slides contained the weighted percentages of characteristics comparing HIV positive, unaware, and aware men and HIV negative men. Demographically, most unaware HIV positive men ever tested, represented by the light blue bar, were over 25 years of age, reported having received at least a primary school education, and were married or living together. Regards to sexual factors, most men ever tested, regardless of testing or reported status, did not use a condom at last sex in the last 12 months. Most unaware men reported all negative partners, and a higher percentage of unaware men reported partners with unknown status than aware or HIV negative men. What is also of interest here is the higher prevalence of men found to be HIV positive and aware of their status who reported at least one positive partner, likely influencing them to get tested, and reinforces the importance of men knowing their status. Lastly, more unaware men than HIV negative men reported 2 or more sexual partners in the last 12 months. Most unaware ever tested had not tested in the last 12 months and were uncircumcised. Conversely, most of the negative men were medically circumcised, demonstrating voluntary medical male circumcision as a good prevention strategy. Unaware men ever tested were also more likely to report a TB diagnosis if visited a TB clinic compared to HIV negative men. Presented here are the results of the multivariable regression analysis of ever tested men receiving an HIV positive result during the survey and being unaware. Each of the points of the graph represents the prevalence ratios along with the 95% confidence intervals displayed for each characteristic. The line crossing the x-axis at 1 represents the reference to which point estimates and the 95% confidence intervals are compared. Those to the right of the line are statistically significant. Unawareness was associated with age over 25, living in southern and southeastern Africa, those reporting no education, those who were ever married, Those who had one or more positive sexual partners or sexual partners with unknown HIV status had a higher risk of receiving an HIV positive result and being unaware. TB diagnosis if they visited a TB clinic, not being circumcised, and testing more than 12 months from the time of the interview. Our findings are based on self-reported testing and behavioral factors, which participants may have not wanted to answer some questions truthfully. Though ARV testing was used to correct for those on treatment, it is likely that some previously diagnosed participants who were not on treatment did not want to disclose their HIV positive status, potentially overestimating the true proportion of men's unawareness. Certain variables of interest were not available across all countries, and the application of some of these findings may not apply due to contextual and programmatic differences between countries. The lower response rates for interview and biomarker components for men compared to women may have impacted the findings, but the direction of this potential bias is unknown. In conclusion, our results found that men who were unaware of their HIV positive status were at increased risk of poor health outcomes and need earlier engagement of HIV services. An estimated 1 million men were found to be unaware of their status, and examining characteristics of unawareness of men who previously tested negative to identify subgroups of men at risk may help to improve yield of testing programs. Such analyses have been conducted where we've worked with countries to develop risk screening tools to be used as part of OPD and provider-initiated testing and counseling. Our findings support need for increased access to and frequency of HIV testing to identify undetected infection in men, including in settings where they're accessing health services and as part of differentiated care and service delivery models. Our findings also support prior evidence that partners, couples testings, and tracing partners' contacts through index testing may help identify HIV positive men unaware of their status. Lastly, given that most unaware men were unsuppressed and reported not using a condom at the last 12 months at last sex, the findings also underscore the importance of condom use in VMMC as a prevention strategy. I'd like to thank my co-authors who provided valuable input on this analysis, the FIA field teams, participants, country ministries of health, partners, and agencies for ensuring the successful completion and high quality implementation of the surveys. This is a link to the paper if you'd like to read more, and you can also access it on the Jade's website. I wanted to thank the organizers for the opportunity to present these findings. Thank you.
Okay, well, thank you so much, Dr. West. That was really just terrific. We're now going to turn to our last presentation before we will shift over to the panel. Our last presentation will be given by Dr. Mansoor Farahani. Dr. Farahani is a physician and public health researcher who's been studying HIV epidemics in sub-Saharan African countries for more than a decade. He serves as technical lead for FIA surveys at ICAP for the Uganda, Ethiopia, Zimbabwe, and Malawi surveys, and he also supported the Cameroon survey. He's now going to speak to us about population viral load and viral load suppression at the enumeration area level and correlations with HIV incidence. Dr. Farahani.
Thank you, Jessica. So let me share my screen. Oops. Sorry, my computer is acting off. Can you see my screen?
It's not in the full. There. I think you need to go to display settings and swap at the top of the screen to the left.
Can you see my screen?
Perfect.
Good morning, everyone. On behalf of my colleagues at ICAP, CDC, and Ministry of Health, one of our key papers from the Jade's Thea Supplement called Population Viral Load Measure. Before I start my presentation, I would like to express my gratitude.
I'm sorry, your audio is a bit faint. If you can...
Let me switch the head.
That seems better.
Is it better now?
Yeah.
All right. So before I start my presentation, I would like to express my gratitude and appreciation for PEPFAR support to make these FIA surveys possible. Population HIV Impact Assessment, or FIA survey, launched in 2014, are HIV-focused, household-based, nationally representative, cross-sectional surveys of adults and children in 14 high-burden countries. Findings from the FIA surveys reveals encouraging results regarding the 90-90-90 targets. For example, viral load suppression among those on ART range from almost 74,000 in Côte d'Ivoire to over 91,000 in Eswatini. I've cut the y-axis at 50% to make the variation conspicuous. Despite all these successes, the overall question remains as to whether achieving these targets can be translated to a reduction in HIV transmission and in turn to a lower incidence rate and eventually containment of the epidemic. Since 2009, when the first reports of community viral load were published, many studies have used aggregate measurement of viral load to evaluate the treatment programs and as a proxy for HIV incidence. Many of these studies have several known limitations and biases that were causes of concern. Two recent studies addressed those concerns. They showed that population viral load or prevalence of viremia were correlated with HIV incidence. However, the results could not be readily extrapolated to the general population because one study used data exclusively from people who inject drugs and men who have sex with men in 22 cities in India, and the other study used the data from prospective cohorts only in rural KwaZulu-Natal in South Africa. To date, no studies have directly measured the strength of association between viral load, aggregate measures in small communities, and occurrence of a recent HIV infection at a national level. Taking advantage of the unique opportunity we had with the FIA data, we set out to answer the following question. Is there an association between population viral load and viral load suppression and the probability of at least one recent HIV infection in the survey's smallest geographic sampling unit or an enumeration area? We used nationally representative cross-sectional data from the FIA surveys implemented in Zimbabwe, Malawi, and Zambia, three contiguous countries with similar epidemic characteristics. The surveys used a two-stage stratified cluster sample design where the first stage selected enumeration areas from the latest census available in the country, and the second stage randomly selected a sample of household in each enumeration area. In this study, we aggregated the data at the level of enumeration area. In the census parlance, an enumeration area is the smallest geographic unit which groups a number of households together for convenient counting purposes. Data were collected from a total of 1,510 EAs in 3 countries in 2015 and 2016. In this analysis, we included data from 1,374 EAs that had at least one HIV positive adults who consented to an interview and blood draw. On average, there were 28 households per EA. We used the blood samples from a total of 58,366 adults aged 15 to 59 years who resided in these EAs. Across the EAs, 59% of the participants were female. We excluded a participant aged 60 to 64 years from Malawi and Zimbabwe for the data to be consistent across the countries. We used a combination of HIV-1, limiting antigen avidity, enzyme immunoassay, and viral load to distinguish recent from long-term infection. Among the 1,373 EAs, almost 93% didn't have a recent case of HIV. Less than 7% had one recent case, and less than 0.5% or only 5 EAs had 2 recent cases of HIV. We calculated various viral load measures as codified by US Centers for Disease Control and Prevention, CDC, and other groups. We computed the arithmetic mean of log 10 for all the viral load measures. For population viral load, we included all HIV positive individuals in the EA. For unaware viral load, we included only the HIV positive individuals self-reported to be unaware of their HIV status. And for in-care viral load, we included people reported to be engaged in care. Lastly, we defined prevalence of viremia as the prevalence of HIV positive individuals in the EA with HIV RNA more than 1,000 copies per ml. Median age of both men and women at EA level was 31. In more than half of the EAs, 77% or more of the adult population had been tested for HIV at least once. Median HIV prevalence at EA level was 14%. In half of the EAs, 75% or more of all HIV positive people knew about their HIV status. In these EAs, median prevalence of ART coverage and viral load suppression among people living with HIV was 67%. As expected, viral load of those on ART was the lowest, and that of the people who were not aware of their HIV status was the highest. On average, population viral load across EAs in log 10 scale was 1.9. Defining viremia as more than 1,000 copies of HIV RNA per milliliter, prevalence of viremia across EA was 36% on average. We used logistic regression adjusted for EA level variables such as HIV prevalence, population size, and mean age of the female population to estimate the probability of one recent HIV infection. These graphs illustrate the adjusted predicted probability of a recent HIV infection at EA level at various viral load levels. In all graphs, the y-axis indicates a probability of having at least one recent HIV case, and the x-axis on the graphs from left to right shows mean log 10 of population viral load, unaware viral load, and in-care viral load. You can see as the population viral load or unaware viral load increases, the probability of having a recent HIV infection at EA level increases as well. We didn't find a statistically significant correlation between in-care viral load and the occurrence of a recent HIV infection at an EA level. These graphs show that the 3 indicators of 1990-19, namely prevalence of HIV diagnosis, ART coverage, and viral load suppression at EA level, are inversely correlated with the occurrence of a recent HIV infection at EA level. The 3 indicators were highly correlated at EA level. It seems that all 3 indicators are equally impactful on predicting the probability of having a recent infection at EA level. But the effect diminishes as the prevalence of each indicator increases. We didn't find any significant difference among these countries in our regression models. In our sensitivity analysis, we use alternative HIV RNA cutoffs for viremic individuals. We set the cutoff point at more than 1,000 copies per ml, more than 100 copies per ml, and more than 40 copies per ml. The adjusted odds ratio associated with 1% increase in viremia at viral load 1,000 copies per ml was 5.3. For viral load at 400 copies per ml, the adjusted odds ratio was 4.3. And when viremia was set at 40 copies per ml, the adjusted odds ratio was 3.4. All of these estimates were highly significant. So the lower the level of viremia, the lower the odds of having a recent HIV case in the EA. So to rephrase our regression result, I can say that half a log rise in mean log of population viral load increases the predicted probability of having a new HIV case by 13%. I'm sorry about the background noise. Or, for example, when the prevalence of viral load suppression changes from 40% to 60%, the predicted probability of a recent HIV infection at EA level drops by 26%. In conclusion, we found a strong association between population viral load and viral load suppression prevalence with the occurrence of a recent HIV-1 infection at the EA level in 3 Southern African countries with generalized HIV epidemics. These results suggest expanding and maintaining high level of viral load suppression may be key to HIV epidemic control in these 3 countries and potentially in many countries with similar epidemics. I would like to take a moment to thank PEPFAR that funded these projects and all my colleagues at ICAP, CDC, Ministers of Health, and all other colleagues in Thea Projects for their hard work in designing and implementing these surveys and their contribution to the analysis of the data. This would not have been possible without your excellent work and patience. Thank you for your attention, and I would be happy to answer.
Great, thank you so much, Mansoor. So now that we've seen the terrific brief video from former Ambassador Burks and had these 4 really outstanding presentations, I'm going to introduce Dr. Laura Porter, who will take over from here. Dr. Porter is the Associate Director for Data Integration and Analysis at the Division of Global HIV and TB at CDC. She guides data functions for CDC's global HIV programs, including surveillance and surveys, and served as guest editor for the Jade Survey Supplement. Dr. Porter.
Thank you so much, Jessica. Hi, everybody. So I want to recognize the really super presentations we've had today and appreciate the questions coming in. What we're going to do now is do a brief Q&A, and then we'll turn to the panel, and then we'll have a closing. I want to recognize a question coming in about the trade-offs in sampling for national level objectives compared to subnational objectives. And in particular, our charge to have a national incidence estimate compared to the utility also for country programs of the subnational prevalence and viral suppression estimates. I wonder, Stephen, do you want to pick that one up?
Sure. So just to be clear, as you mentioned, the primary objectives are driven by precision, principally, particularly in the later Thea surveys around subnational estimates of viral load suppression, not HIV prevalence per se. And so to get that level of precision, typically a 95% confidence interval plus or minus 10%, we need a sufficient number of HIV positive cases at those subnational units, regions in the case of Tanzania. And in regions, subnational areas with very low prevalence, it is difficult to get sufficient number of cases. So we have taken a tiered approach to approach to sampling in countries where we have regions that have very low HIV prevalence, that is essentially conceding that it will be difficult to get very precise estimates of viral load suppression in places where we have low prevalence and low burden of HIV. So just to understand that we are striving in general to get sufficient HIV positive cases in each region, and if that's not feasible, given the timeline and the budget for a survey, that is a trade-off that we accept. Thanks.
Thank you so much. I also want to recognize that we have questions coming in about the conduct of the surveys in the context of COVID-19, which you touched on, and which we will have a later seminar on, as well as the ability of these surveys or comparable approaches to actually measure COVID-19. And so I think that I'm going to recognize a couple of other questions and then take those into the panel perhaps now. Another question coming in, a couple of questions are about both what we've learned and what we've tried in terms of strategies to better reach men in testing and prevention. And I think recognizing that reaching men remains a challenge in our global HIV programs. So I think now, in the interest of time, I'd like to move to the panel and introduce our panelists. We're very pleased to have our panelists join us today. We have Dr. George Bello, who is working for ITEC Malawi as the HIV Surveillance Technical Director and seconded to the Ministry of Health to support the implementation of HIV surveillance activities. George was the principal investigator for the first FIA in Malawi and is a guest editor to the Thea Supplement. Welcome, George. Ms. Rejoice Nkambule is the Deputy Director of Health Services in the Ministry of Health in the Kingdom of Eswatini. Ms. Rejoice was the local principal investigator for the first ever population-based HIV survey called the Swaziland HIV Impact Measurement Survey, or SHIMS. Since then, she's been the chairperson of the co-leadership group for the subsequent 2 SHIMS surveys. She provides overall leadership, coordination, technical support, and policy guidance for the implementation and dissemination of the surveys. We're sad to say Madam Rejoice is unable to join us today from Eswatini. Our thoughts are with her and others for their safety and well-being in the country. Dr. Seban Nsazimana is the Director General of the Rwanda Biomedical Center. He has extensive experience in HIV program design, strategic planning, implementation, and operational research with a focus on global care and treatment of people living with HIV. Dr. Seban was also the principal investigator for the Rwanda FIA survey in 2018. And then Mr. Bright Puri is the team lead of education and community mobilization for the FIA project at ICAP. Since 2015, Bright has been responsible for coordinating overall education and community mobilization activities across all FIA countries. So I wonder if we can have the panelists join us on video. Thank you so much. So I first want to express our gratitude, like Jessica did, to the communities who welcomed us in their homes and to conduct these surveys, and to say what a privilege it's been to be in partnership with all of you on these projects. We've heard from presenters today about experiences of putting the surveys into the field, about lessons learned and the results of these efforts to inform HIV programs. I wonder if we could start there. And with the questions that we've gotten in, to first ask George and then Dr. Seban to reflect on your experience of the surveys in Malawi and in Rwanda and how the results informed or changed your program. May I ask you to start, George? Thank you so much. I think you're muted still, George. Thank you.
Yeah. Thank you very much. I think I will just indicate mention 2 uses. We've used our FIA data to inform our programming, but and also would want to use the FIA methodologies, how we have used it to implement COVID survey, which we did at community level. So in terms of usage of the FIA, we did use it to identify geographical areas and subpopulations in need of services. This relates to like ART treatment. We have used this data to understand the gap in treatment coverage, as well as in viral suppression by geography. So in our case, we had to do it at different zones. So we had seen some zones having some challenges, and also by sex. And we have also seen that men tend to have more challenges in terms of accessing these services. And also by age, we have also noted that those who are the youth, they have challenges to access these services. So this information helped in terms of setting up some interventions and also program planning. Secondly, we also used this FIA data to generate data at small areas. Like in this case, we used at district level, where we had to estimate a number of people living with HIV. And in doing that, we had to use these small area estimation methodologies to come up with the numerators at district level as well as denominators. And by doing so, we're able also to identify, to come up with the number of viral suppressions at the district level. And this helped in terms of program targeting. And in terms of the COVID, the FIA methodologies, they are very complex, and we had to adopt some elements within that FIA methodology. Primarily, we had to adopt in terms of how to implement the COVID survey at the household level. There where it involved in a collection of samples from the nasopharyngeal as well as blood, and then we had to adapt in terms of how can we ensure that these samples reach the designated labs within the reasonable time. So in our survey, we're able to do it within 6 to 8 hours. All samples were frozen, and we're also able to now to ship these samples to central lab for some in a cold chain manner. So I think we feel these FIA surveys have indeed helped in terms of guiding how similar large surveys can be implemented. In this case, we had to use this COVID survey. And also it's worth to note that, we had also to return results to the participants. Unlike the FIA where they had to send samples, returning results through facilities, in our case, we had to use the phone to call the participants. In case of people are not there, they cannot be reached using the phone, then we had to use this rapid response teams to send these results. Yeah, thank you.
Thank you so much. Dr. Saban, over to you, please.
Hello. Thank you very much for having me. And this is indeed an interesting conversation. Appreciate all the previous speakers that I had a chance to know through these projects that have helped different countries, including my own country, Rwanda. When we did the FIA planning in 2018, we wanted to answer a number of questions: where we stand with the prevalence, incidence, viral suppression. And we had a chance also for the case of my country to ask ourselves about other viral diseases that we're planning to combat, including hepatitis virus. So we had a chance to combine different research questions that we had to answer as a country. And I want to recognize also the fact that having worked with different partners, including PEPFAR, CDC, ICAP, and the University of Maryland has been mentioned, and others in HIV response for more than 2 decades, we all had the same kind of objective to attain and understand where we are today. So these results, as you asked, were quite useful to help our government planning, different planning levels up to the strategies of the health sector, HIV elimination plans, ending AIDS by 2030. This was a kind of a baseline to start with, looking at where we are in 1990, but also thinking of 95. We're also able to use some of this data to discuss with other partners who are providing support. For example, the Global Fund that also needed this information in planning perspectives. But more importantly, for me as a principal investigator, we're using this opportunity to train our researchers throughout the process in planning, designing the study, implementation, going up to the community level and households, how we continue to do such kind of big surveys in a short time, and again, keeping the standards and using the right resources and local people that were enjoying working with the experts from different partners who were with us throughout this period. So basically, this is a combination of so many benefits of doing research. It's not just to have data and improve policy, but also is to create more partnership, more friendship, more future researchers, and more infrastructure in place. So it has been really amazing to work with all the people I had a chance to meet. And till now, we're still discussing this, this interesting project.
Thank you so much. So grateful for your comments, Dr. Sabin, and to Dr. George. I wonder if I might turn to Bright and ask you whether you might like to comment on the role of community mobilization to enhance awareness and acceptance of the surveys, and to address challenges that we meet as we are in the field in implementation. Thank you.
Thank you so much, Laura. Good evening and good morning. Before I start, I would like to say what I'll be saying is representative of so many of my colleagues that I worked with in different countries, the community mobilization advisors, the community mobilization coordinators, and also the community mobilizers on the ground. Collectively, I would want to say what Stephen started off with, to mention that normally and usually community mobilization is a forgotten part. It does happen. However, I think there's increasingly acknowledgement of the value of community mobilization. And I want to hasten to mention that the Thea Project did recognize that by including community mobilization activities right from the protocol and allocating a budget for that, that facilitated us to do all the work that we did. In general, I want to say communities, especially in the rural areas, they're quite hesitant to participate in programs that might seem to be emanating from outside of their communities. And so to try and prepare them, for them to accept the fear, we had to come up with a robust kind of community mobilization strategy, which strategy, of course, was not cast in stone. It was across countries. It was very flexible to respond to the different cultural contexts and to deal with those issues in the different countries. And so what I can say, while I wait for questions that can be asked and I can answer those questions, we did have a lot of opportunities. And those opportunities, we utilized them to the maximum. And also we had challenges. And of course, I heard somebody mentioned on COVID. Of course, I've been working with the FEAR from the first FEAR. We had fewer challenges, but a lot more because of reaching the men. And then now when we have COVID, again, we are seeing different challenges unique to what we would have experienced in the first FEAR. Very quickly, I want to say nothing and not one size fits all communities. What I experienced together with my colleagues was that within countries, there are differences. Within cities, there are differences. We had challenges with urban setups. There's a term we coined to say, look, you have gated communities, those estates where the affluent people would live. What strategies would we use to try and reach those communities that are part of the survey? And also you have other communities within urban areas, the high density communities Those we had it easy, but however, we still had to devise strategies that could bring those crowds to our messages and utilize what we were trying to use there. In the rural areas, we're a bit lucky because we could call big communities for meetings and be able to send our messages across. However, differences again between men participation and female participation. How to reach the men was such a difficult task that we had. And in every other country, we would devise a specific strategy that would try. For instance, in Lesotho, where we know men are so much political, they want to listen to political debates and everything else. We had to target programs that would speak to that. And in Malawi, for instance, George is on the call here in Malawi, where we're in the rural areas again, if people are farmers and everything, as community mobilizers would follow them up to the farms, talk to them, speak to their masculinity issues, and allow them to realize they have the power to change the epidemic. When we talk to them and say, for instance, that, look, you're the head of the household and everyone is looking up to you. If you're able to accept to participate in this survey, your whole family and the whole community will look up to you as a role model. That kind of messaging targeted directly to the men and their masculinities kind of helped enhance their willingness to participate in the surveys. And beyond that, we had to reduce the scientific language, the jargon, try and make it into the local languages, simple for people to understand in the communities. Allow me to just highlight one that you say, if you say random sampling, because in certain communities, people would ask us, why would you choose my neighbor and not choose me to participate in this? We would say, oh, it's random sampling. They don't understand that. So we will have to use language that they're familiar with. And remember in trainings, we would always try and say, look, guys, why don't we say, because this is familiar with everyone, why don't we say, if you're preparing stew, for instance, beef stew, and you want to test whether or not the salt is sufficient in that pot and or the beef stew is cooked, you're not going to scoop the whole pot for you to test. You're going to pick out one piece of beef stew for you to know there's enough salt and so. So that's the kind of language you are trying to simplify in order to engage the communities. I want to stop there, and I'm happy to answer any questions that may be related to community mobilization. Thank you, in the interest of time.
Yeah, thank you so much. I'm so grateful for you highlighting the importance of this in both fielding the surveys and then advancing the HIV programs in these areas that we've recognized challenges. I'd like to turn over to Dr. Drew Vetch for our closing. Drew is the team lead for the General Population Surveillance Team in the Division of Global HIV and TB at CDC. And he's a co-author on multiple papers from the Thea Supplement, and he led the paper describing changes made to the HIV incidence algorithm based on Thea survey data. I'd like to welcome Drew to do a brief summary and take us into closing. Thank you.
Thanks, Laura. In the interest of time, I'll keep the remarks brief. I just wanted to highlight the importance of these surveys in that we were able to measure progress towards the UNAIDS 90-90-90 targets here. And those targets were met in multiple countries, Eswatini, Namibia, and Rwanda, with overall viral load suppressions greater than 73%. And we did show improvements in some of the countries where we had repeat surveys that Jessica described at the top of the webinar in Eswatini, Lesotho, and Zimbabwe. But that progress was not met universally. There were variations by sex, by age, and by location within the country. For example, Christine highlighted that men were less likely to be aware of their HIV status. And generally across countries, we found that young people less than 25 years of age were less likely to know their status and less likely to be virally suppressed if they were positive. I think I wanted to make a point about Dr. Saban's comment on capacity building. We, in addition to the articles in the supplement and the papers that have come before and are in progress now, and the 65 presentations made at scientific conferences, we have data sets that are now publicly available on the partner websites for use to ask and answer questions that haven't already been addressed by the tremendous amount of work that's already been done. And so I want to encourage folks to take a look at that and to collaborate on on future work. In addition, Hetal mentioned a biorepository of residual plasma and dried blood spots. And we've had colleagues in multiple countries, mostly in Nigeria, through their multiplex platform, look at a variety of different non-HIV conditions, including assessing childhood immunization status and looking at prevalence of malaria, neglected tropical diseases, and other conditions. And so I think that capacity, both the data and the repository, are an important contribution to the Thea program. And lastly, I would say that the surveys really have been an intersection between public health program and surveillance, in that we were the first survey to return HIV test results immediately in the household, and also the CD4 results as well. Viral load results were sent to the clinic where persons were seeking treatment. So we did make that contribution of program in addition to the survey. Of the more than 24,000 HIV positive folks that we found, a little over 5,000 were newly diagnosed, and we were able to link them to treatment. So I'll close by saying I think that these surveys are critically important to evaluate the PEPFAR, the Global Fund, and the national contribution to HIV in all of these countries, as Ambassador Burks said in her video. And we look forward to doing another round so that we can assess progress towards the 2025 95 targets. I'd like to thank all of our panelists today and all of our speakers. I would encourage the more than 225 attendees to look at our supplement on the Jade's website, and also to look for the recording of this webinar. So thank you all for attending today. Thank you very much.
Okay, thank you all for staying with us a little bit past the time. And we'll sign off.